We are living in a world which I call a flexible molecular medicine.
So obviously you don't just take a radioisotope off the shelf and then stick it into a patient, because that would go everywhere. You need to target that radiation. How is that done? Hey guys, it's Charles and welcome to Chat GCP, a medical science, clinical research and commercialization podcast. So today we've got something a little bit different to usual. It's a new area of interest of mine personally. I'm really happy to introduce Madhu Vyas, who's going to talk to us through nuclear medicine, radiochemistry, and some of his academic pursuits. So sit back, relax, get amongst, and learn something new. So Madhu, great to have you on the podcast today. Thank you so much for your time.
Thank you so much, Charles. Thanks for having me here. It's really nice to, looking forward to it. What else I can share on this podcast.
Yeah. So radiochemistry, nuclear medicine, these sound pretty science fiction type topics. When people hear the word nuclear, I think, maybe I put myself into shoes of mine from 10 years ago. I might think of that glowing green stick on The Simpsons that, that Homer accidentally carts around all of the town. And you wouldn't typically connect nuclear with medicine, and yet it's a very flourishing and important field. What is nuclear medicine from a high level, and why is it so important?
So, like a nuclear word, whenever any patient even comes to the department, they also say, are you going to blow me or glow me in the dark? So the Simpson factor always, go and just keep running behind your mind. Nuclear and medicine. So it seems it's like a very good combination of one important thing, that how safely you can use nuclear energy for betterment of the human being. So like we can say clear energy is the one word we use for the productions of the like electricity and other aspects that in our life. Nuclear medicine is also following the same thing, but we are using some radioisotope for the diagnosis and for the treatment purposes. So it's a branch of the medicine where you use these isotope for the patient by various method you injecting in their body. So say injecting by intravenous, intramuscular, even we give sometimes very tasty sandwiches to them, which they eat.
Radioactive sandwich.
And radioactive sandwich. And so honestly, those are sandwiches, they just love it all the time. And we can see the, information way precisely. And if I actually give a little bit layman language and also scientific language to define this. So it's the method where any organ in the body was not physiologically working correctly, so you inject some of the James Bond type radioisotope agent, tagging that with the pharmaceuticals, and that will follow the physiology of that organ instead of affecting or altering the function of it. And if something is wrong, it will show you because you are generating some rays, which you can detect with some cool cameras.
Yep.
And this is how thing works.
Yeah. It's quite incredible. But when you hear things like radioisotopes, what is a radioisotope? So it's a iteration of a atom with slightly different molecular structure, or nuclear structure rather.
Yeah.
And because of that change, it is emitting different kinds of radiation. So there's different types, right? There's alpha.
Yeah. So the first part was like a little layman, but need to understand what helping me to detect that. So for that, we need to go a little bit basic of the radiation physics, not too much in detail. So radiation is actually, you have heard three types: alpha, beta, and gamma. And one is X-rays, because the person who produced it or introduced it, William Röntgen, first time, he couldn't actually differentiate what kind of thing it is. So he XYZ, how we say this? That's how he said X-rays.
Right?
So this is how the things, these type of radiations available. Now you pointed about radioisotopes. So what exactly happens in the element world or the atom world, that you have a large atomic number element and they are stable. For example, lead, uranium, plutonium. But there is a kind of an imaginary line that we call, based on the atomic structure, that if your neutron and proton level get destabilized, they try to get stable to come back to the NP ratio that we use the word in physics word to 1. So for during that process, they do some sort of, byproductions during that journey. And that byproducts are different types of product that we can use for various uses. Those are radioisotopes, radioisomers, isobars, so isotones. There's different categories based on their various combination of these subatomic particles. So these radioisotopes have different characteristics. Like some of them have a long half-life, some of them short half-life. So what we do, if I really want to inject something inside your body and I say, hey, I want to inject you something which is like a half-life of 5,000 years. So you say, no, I don't want that. We need to find some ideal radioisotope or radioactive substance, that's the right word, which is a short half-life. It should not alter your function, and it should not emit harmful radiation. So now I come back to the point where I said there are 3 types of radiation: alpha, beta, and gamma. Alpha and beta, it cannot cross your body. Like alpha even cannot cross the paper. Beta can cross paper, but cannot cross the perspex, like a plastic. And the gamma can cross any thickness, and they travel by the speed of light. So that means if I want to diagnose or detect something, so I will trace a tech with something which is emitting pure gamma emitter and also short enough half-life, and then it can come out from your body by 2 system excretory or alimentary canal easily, so it should not spend more time in your body. So this is how the radioisotopes designs. And then you inject or inhale or ingest, whichever way you want to use, and then you detect those radiation outside of the body with the help of some scanners that we call in the layman language gamma camera or the PET CT, which you have heard a lot.
Yeah. So I hadn't made that connection between essentially that you're destabilizing the nuclear structure and it's emitting that radiation to try and find the stabilization again, right? And that might be the alpha rays, beta rays, or gamma rays. That's quite interesting. And so you're selecting the most appropriate radioisotope for the purpose that you have, and that might be therapeutic or it might be diagnostic. There's a whole raft of different. I mean, if you look at the periodic table, there's a lot, and down the lower end, the bigger ones, the more suitable for this. There's a huge swath of different elements to choose from, but they're not all suitable, right? Because when you said plutonium, I'm just thinking, like atomic bomb. Uranium, same goes. But then you've got lutetium, which is very low on the periodic table, but you've also got like fluorine or 18F, which is comparatively higher up. So there's no like one size fits all.
No, it's not actually. And if I would say the current nuclear chemistry where it is going, it's even we can use some of the heavy element like a new radioactive isotope lead-212 is really good for the theranostic purposes. Now, I just in a simple language, I always explain to my student, I always stand in front of them and say, my right hand is the periodic table S block. My left hand is the P block, and my legs are lanthanides and actinides, and my tummy is the D block, because my bread and butter radioisotope sit in the D block. So why that D block element? Because they also known as in chemistry transition element. So word itself, define that they have an extensive oxidation number. So a little bit of chemistry here.
Sure.
But it is interesting that if you have more oxidation number, you have a better chance for that isotope or that element to tag with any pharmaceuticals effectively. You can say it's a more, claws which they can hold the things. That's the thing. So technetium-99m, which is the metastable state of the 43 atomic number technetium, it's basically one of the radioisotope that we call in nuclear medicine a workhorse of the nuclear medicine. So 90%, if I would say the process globally, you are doing scan, that based on technetium-99m. Right. But now, if I want to say use some radioisotope for the therapeutic purposes, so as you said, it's all fit doesn't work, then you need to go in a different channel. You say, okay, I need a pure alpha emitter because my aim is that I can see the bone mets, but I cannot actually, but I don't want to go too thorough to the bone marrow, but I want to hit that lesion. So you go by the effective depth they will hit.
Yes.
So that's the alpha emitter you will choose.
Yes.
Then you want to say, I want to treat, but I want to see as well. So you want to choose a radioisotope which is emitting beta radiation as well as the gamma radiation.
Yeah.
So you choose lutetium, which energy is like a good beta max, 500 plus, and the gamma rays of 3 different energy, 114, 108 kV, and around 208 kV, top of my head. So that actually helps you to do what the bullet you are firing, you can see from your scanner that bullet received to the target or not. Right. So what is the point of all this? That this is something which is really interesting part, that you, in the periodic table is like a whole gamut for you. You need to do what? Take a nuclear reactor, destabilize one high atomic number element, and then it will give you byproducts out of it.
Yeah.
Same thing we do, like a radiation can be produced, isotope we produce by 2 methods. One is the nuclear reactor, by fission method we do.
Yep.
And the second one, cyclotron, which is many people heard about. It's like an acceleration. So we can use these 2 methods producing various types of radioisotopes and in their different characteristics. So it's like a whole periodic table is my playground.
Yeah.
I can choose what I want. Yeah. And honestly, I tell you why, because I was in Zurich like a couple of weeks ago, and there's a Paul Scherrer Institute where we were trained in one of the world's largest linear accelerator of 72 MeV. So if you go by their floor, they have that whole line of stability which I was talking earlier, NP ratio. You can see that if you destabilize, how many isotopes you can produce. And up to 5 floor, that line was going. And they were saying they are going to make that, like on the wallpaper.
Yeah.
What they started and how this is going. So you can easily see, okay, if I destabilize lead, what I can get all 34 types of isotopes. If I destabilize fluorine 18. So it's like...
And they'll all have all different characteristics.
And all on the wall.
Yeah.
So there's all...
So for any one element, there's not just one radioisotope.
No.
You can create multitudes and they will have different characteristics. They might be more alpha leaning or more gamma leaning or a bit of beta. So that's amazing. Yeah. So you've got like this assortment, this pantry from which to choose. And it's not just about the element that you choose, but it's also the range within the potential radioisotopes that you can choose. So just as kind of paraphrase, if you're looking purely imaging, you want like a gamma emitting thing. If you want something that's really narrow but therapeutically irradiating, you would go for an alpha because and beta. Okay, yeah, because it doesn't go quite as far. But the only caveat with that is that you wouldn't be able to see where it's gone with a conventional PET CT or PET MRI camera because it doesn't go further enough.
Yeah. So this is how the things work.
Yeah.
And like as you said, there's not a one range or one is available. They've been like investigated for years.
Yeah.
And like lutetium-177, if you get like isotope at your lab, they will send you a report that lutetium-177 also have lutetium-176 or not. Is that any ytterbium-176 there or not? There iron, magnesium, zinc, cadmium. So all their impurity will exist, but there is some sort of limitation. So they do purification of it with the different methods. So it's a long process before you finalize and say to those agencies that this is what I want to use.
Yeah, indeed. So obviously you don't just take a radioisotope off the shelf or freshly made from a cyclotron or via fission and then stick it into a patient because that would go everywhere. You need to target that radiation, whether it be for imaging or whether it be for therapeutic purposes. How is that done?
Yeah. So we need actually like a pretty robust hot lab atmosphere. We call it hot lab. So we say we are hot. That's why nuclear medicine is cool and hot. So you need
No one else is calling you hot, but you
no,
got to call yourself
yeah,
hot,
I
right?
might call it myself. No one calls us. So we need a certain process, and those steps actually like involvement of various equipment. So, for example, if I'm making technetium radioisotope, so some kits come like ready to use for that. Some you need heating of that thing. So pharmaceutical comes which you are targeting. For example, I want to see the kidneys, and kidney functions. Kidney filter your blood by two methods: one by glomerulus, one by tubular. So if your kidney function started deteriorating, 20% part which your glomerulus is filtering, that is always get affected first. So your doctor want to check, okay, if the GFR is going down or your one of the side is actually detected on ultrasound obstructed, they want to check whether the function is okay or not. So if we remove the obstruction, can work. So what we do, we use technetium 99M from myself. I'll take DTPA. There's a name of a pharmaceutical, not radiopharmaceutical, just a pharmaceutical, before it tagged with the radioisotope. That's how they use the term. I will mix that directly and then leave that for 5-10 minutes, and it will react and make the technetium 99M DTPA. And what DTPA does, it designed and experimented for many years in the lab, in animal and then human, and then like in vitro and in vivo stability, that it will go to your heart once you inject, and then go to the kidney and filter by glomerulus method, and then will come to your bladder. So if the kidneys are functioning normally, in half an hour you should see the kidney, like a perfusion, uptake, and the clearance phase.
Yes.
And this is how we actually design. So we call before we react that isotope with the pharmaceutical. They are pharmaceutical radioisotope. Tag radiopharmaceutical.
Yeah.
So we heat them, we mix them, we use sometimes some complicated synthesis module which actually have various steps, and then you check the quality control of it. So you need to have certain system in place which assure you that what you have prepared, it is okay to use or not. And for that there are certain criteria from European Pharmacopoeia and United States Pharmacopoeia. So we always have those methods, and this is like a standard practice that you need to do. So
Because the last thing you would want is that the reaction or the combination of the two, the conjugation, has failed, and then you're just giving untagged radioisotope that goes everywhere and isn't doing its purpose.
And you don't want to do that.
No.
Because if you inject untagged stuff, you're already putting like radiation inside patient's body. So you want to make sure there's a rule of IAEA, and which is forced by ICRP. So IAEA is International Atomic Energy Agency, and ICRP is the International Council of Radiation Protection. And they gave us, as a radiation professional, whether I'm in whichever field I am, a LARA, as low as reasonably achievable. So you always check that you need to follow that law, that whether I'm doing this is for the correct, what is the benefit of it, what is the risk of it, and how much risk I can minimize before I'm introducing that radiation to the patient, whether it's a CT or isotope. Apply similar.
Sure. So there's kind of like two parts, or maybe a third part as well. So you've got your radioisotope, you've got your targeting molecule that might be a pharmaceutical. So it could be a peptide, a small molecule. It could be an antibody. There are some new products out there with antibodies, and the two can be combined. And is it because the radioisotope has that high oxidation number that it just naturally, occasionally, just wants to connect with the pharmaceutical, or in some instances, do they need a helping hand by like a linker or something along those lines?
Yeah, so that's the point. So we need actually, it depends which isotope you're using. So if you're going in the heavy metal, you need to put the linker because they stabilize it. You can say it's like as the molecular weight is increasing of your peptide and the weight of your mass number is increasing, you need to keep them stable.
Right.
So linker will be important as well.
Some fortification, some structure.
Yeah, so it's not like they just don't want to come together. You need to bring them together sometime. And it depends what you're targeting. Like, for example, molecular antibody, you use that like some of the, you just mix them, but you will not heat them because you want them 37 degrees centigrade. But if I'm using lutetium antigen, I need to heat that for at least 100 degrees centigrade. or DOTA, because they need to be like tagged properly.
Yeah.
So it's a different mechanism. Linker sometimes actually can, doesn't go well. There's a different choice of linkers available. Like we use DTPA sometime, and multiple chelators you need to use as well to stabilize them. So it's a pretty much like a chemistry involved in it to keep these things for a longer life for the stability in vivo and in vitro.
Gotcha. Yeah, so that's super interesting. So you, again, going back to our pantry, you're selecting your radioisotope, you're selecting your linker if you need one, and you're selecting your targeting molecule. So it's typically a pharmaceutical to take it to. So if you want to image the liver, something that is really specific for the liver, to the brain, really specific to the brain, or something like, or something that's not working quite well in the case of like a cancer, something that is unique to a cancer, which is also... So I've seen that 18F fluoroethyltyrosine is used for the imaging, well, can be used for the imaging of primary brain tumors or metastatic brain tumors, because brain tumors are really hungry for, amino acids.
Amino acid, yeah.
So fluoroethyltyrosine is, they just gobble it up. So if it goes to if the FET goes to the brain tumor, the fluoride, the 18F, sends out the gamma radiation, and you can see it on a...
Yeah, and you just said right thing. It's like it's a hungry for something, and that hunger you need to actually find. So it's like now this is called how this thing is coming from lab to your bench. So I'm like on the user end. The researchers are working behind on the scene. So for example, and this is very exciting, and I think this I can take a little longer to explain it. So current time is actually molecular imaging. Nuclear medicine word is gone out of the practice. Now we are more molecular imaging, because you are talking about antigens, antibody. Even we are now started talking about the intracellular environment. So now we are moving into what will happen. You can predict even earlier, and that is actually biologically possible, and we can create some biological molecule which you can target that. So for example, there's you said about the FET for the brain, which is hungry for the amino acid. So what this one was actually detected biologically. So you can see how biology, medicines, and chemistry, and then physics from the things are coming together. Similar with the metastatic castration prostate cancer. When the prostate cancer started, like exhausted, patient is exhausted already from all the treatment, and they are medically castrated and surgically also, and still PSA is rising. So that situation, there is an antigen receptor started growing that we call PSMA, prostate specific membrane antigen. So you can target something to see that, and then also you can treat it. Similar with like now, sometimes PSMA treatment doesn't work because 65-70% success rate, even 70 I'm telling a little bit higher, 65 is that number. So you can target antibody, like how you inject the mRNA based vaccine, similar type of antibody you can create. So that's the another step. And even if that thing doesn't work, you can test another option that is called fibroblast activation protein, which is actually intracellular environment of the cell creates some fibroblast, which is the like a mostly macrophage byproduct. And in 28 types of tumors, those fibroblasts actively persist, even tumor is in an initial stage. So in 2019, SNMMI, Society of Nuclear Medicine Molecular Imaging, they produced image of the year, which was showing all those 21 type in that, but 28 at this stage. So fibroblasts. And then another, chemokine receptors, which is actually 50 exist in human body, and their ligand 20 exist in human body. CXCR4, that's the fourth receptor we call, which bind very well with CXCL12, which is the binding, and that can be target 30 types of solid tumors and the hematopoietic syndrome, hematopoietic like leukemia and all this. Amazing. So that bin earlier was a part for the medical oncologist while they were doing the chemotherapy, and that was like not labeled with radiation. But currently we can use that for any solid tumor, like even multiple myeloma, that due to the chemokine receptor I can do it, and I can detect that. new CT scan doesn't show anything. For example, bone scan is inconclusive.
Yep.
And FTG scan, if you do sometime, it's not helpful. I've seen recent case from published in 2023 October. It was showing very good pictures of chemokine active receptor. So this is the time
Yeah.
where we are living in a world which I call a flexible molecular medicine, where I can go anywhere and I can change my plan because I have more options available. 20 years back, it wasn't.
Here's a quick message from today's sponsor, SAPPRO, your clinical trial pathway partner. Engaging with SAPPRO as your clinical trial pathway partner will keep you and your collaborators on track, ensuring your strategic objectives are met and that your product is approved as soon as possible. For the small biotech or pharmaceutical company, SAPPRO offers tailored CRO solutions from start to finish with their reliable alliance partners. So we've going from really blunt tools.
Yeah.
I mean, that's just the nature of the beast anyway in general, right? Like chemotherapeutics are blunt tools. Kill something that grows fast.
Yeah.
Ideally kill the cancer before you kill the patient. To more targeted therapies, which are like monoclonal antibodies and the same thing is happening in the imaging space and the therapeutic space around molecular.
And the word imaging and therapy now got a word Theranostics.
Theranostics. Oh, it's dangerously close to Theranos though.
Yeah. And the word actually came not from originally from nuclear medicine. It came from one of the pharmaceutical company in 2001. They used the word for the Herceptin, and that's how you detect and treat in the breast cancer.
Yeah.
But this approach exists since 1940 because iodine therapy for the thyrotoxicosis and for the thyroid tumor, we are doing in nuclear medicine since very long. So you can detect 364 keV either with the uptake probe or then gamma camera scanner started detecting it. So that approach, imaging and therapy, that's a superpower.
Yeah.
And what is the beauty of the theranostic? The one thing which I want to disclaimer here, that we are not overarchingly saying that this is the only solution. What is the best suitable for the patient that should be applied, and this is physician's choice. But if I talk about the theranostic and this targeted therapeutic approach, or we call it precision medicine, that's another word, very cool words coming. Those all words actually comes pretty closely what practice we are doing in molecular imaging space.
Yeah.
So we can see and we can treat. As I say, PSMA, prostate-specific membrane antigen, first I will see that, and then I will treat it with the help of lutetium. So choose different isotope, who is gamma emitter, different isotope, which is actually beta emitter, and you can treat it. And also you can see that with the same isotope, like lutetium-177, and you see, yes, I have treated correctly. Let's see how the outcome will come. Absolutely. And outcomes, and the important thing which is here to be mentioned, theranostic space give a lot of comfort, or who knows how much it will grow. And the $1 billion I can say is many, and interest is coming, but it's safe for the patient's point of view because it hit only target.
Yeah.
It's go precisely there. It's not affecting the physiology. So side effects are there, but not too many. But it depends where it should be used.
Definitely. So if you got a right targeting moiety, so the pharmaceutical that goes exclusively to the tissue of interest or the target of interest, being a cancer, that radiation, you'll know the kind of radius, the length of that radiation that it will go to, if it's gamma low energy or if it's alpha beta whatever. That's very precise if you get it right. But I can imagine if you don't get it right, it goes everywhere. The target might do a little bit of targeting to what you want, but it also has off-target effects. Other organs that then get damaged by the radiation. So that's not ideal. So it's not a panacea, provided you select the right thing and then you're targeting for the right thing. It's just potentially another really helpful tool in the toolkit, right? I mean, but in cancers, I mean, it's
yeah, it is, and the thing is that how you do this, like that's what the radiochemist role comes, or all the tools which you are using, verify the quality, and can say now 10, like 9.97 out of 10 time you will not fail because of the consistency, and you can pick the failure if the product is not correct, you will not inject. So obviously we are injecting something which is we verified. and that can give better results. But yeah, it's what I agree with you. what you said. Yeah.
So why don't we pivot to talk about nuclear medicine or molecular imaging in New Zealand? I mean, I worked for a radiopharmaceutical company. Prior to that, I didn't realize there was much happening in the space in New Zealand. But you're very active, both academically but also at Mercy Hospital, and that's one of the few places where these kind of techniques are available. Is that right?
Yeah, that's true. We can't say that this was the only space where it is available. It's in few bits and pieces been publicly available, but Mercy, I would say, been playing an important role to shaping the whole nuclear medicine's practice approach in New Zealand. So we are the first in many things. Like I would say, 2010 we bought the first PET CT scanner. So otherwise, before patient were going to Australia for that.
Right.
Yeah, I know. It's like pretty much you're going for Australia for a PET scan in this world in 2010, like not far.
It's
14
just
years
like
back.
yesterday.
Yeah.
You go, oh my God.
Yeah, so we bought the first PET scanner, and now we have in private some of the other PET scanner available across the country. Then in 2015, we were the first who actually started gallium 68 label radiopharmaceuticals services, like a PSMA.
Yep.
So our clinical director and Dr. Remilim, he is pretty active into the research, so he introduced that. Then we bought gallium 68 dotatate, which is till date we are only providing in the country for the neuroendocrine tumor. Wow. And then as we going in the same directions, we had enough tool, so we thought, why not we go for the theranostic part? So obviously then we started lutetium-177 PSMA, which previously again patient were going to Australia, and that was quite costly. And if you look at the number of the patient that we have in a country with a prostate, so that was like a huge help for them. And neuroendocrine tumor treatment, then Pharmac approved in 2019. Right. So we are the one who only providing the radiopharmaceutical supply. So we are supporting the National Therapeutic Center in Auckland Hospital. So it's like Mercy is playing a very important role at this moment to keeping things in-house and keeping those things for the patient. And I do this journey with my patients because I'm involved actively and heavily with the patient's treatment. I hear their stories. It is important for them. If somebody is traveling from Whangarei to Auckland, it won't hurt. If somebody is traveling from Whangarei to Perth or Melbourne, it hurts because you have to plan so many things.
Oh, yeah.
And also, like, for example, therapy you're getting, you need to stay at least for 3 to 4 days in the town.
Yep.
Because you cannot travel for air or road if you have to sit next to someone for the radiation safety point of view. So Mercy has provided a lot of things, and so many things in the pipeline, and we already declared our first cyclotron of the Auckland.
Yep.
So that's something is interesting thing. We are looking forward to it. This will be like a very high energy cyclotron, which would be like not only able to produce fluorine-18, which is currently produced in Wellington in our country, but then we also start producing some other stuff which is cool and not available anywhere. So Mercy is shaping the whole, can say the future of nuclear medicine in New Zealand.
And what does that look like? Because there's clearly a lot of promise in nuclear medicine and molecular imaging, and part of a lot of the discussions I have on this podcast is about making sure that New Zealand doesn't miss out on those advancements. Because we are part of the first world. We're technologically advanced, but we're at the bottom of the world. We're kind of cut off. We're not a big market, so we're easily overlooked by big pharmaceutical companies or big providers or whatever. So we do need institutions like Mercy that are kind of bringing that technology here, willing it into existence. Otherwise, I mean, no one's going to do it for us on our behalf for free, right? So there has to be someone that's championing these for New Zealand. So it's awesome. But what is it? One of the other things is that one of the important themes from this podcast is education in these areas. Is there much happening in terms of homegrown nuclear medicine technologists and radiochemists? Because that's such a niche thing, right?
Yeah, so obviously, if I would say, when I came to the New Zealand 2014, so then I just looked around in my first conference when I was in Auckland, and I saw it was like a Commonwealth world.
Yeah.
So no one from New Zealand,
No.
everyone from outside.
Sure.
Our Aussie friends and other, everyone. So we just like thought at this stage, obviously I'm also overseas trained. So we thought, why not we have our own? I don't want to stop someone to come. Obviously, like I was saying, all of us are really amazing people who are shaping and serving this country. So for the education part, University of Auckland started a post-graduation course in 2015, which I think officially launched 2016, the first batch. And what was the importance of that course, which currently I could say we already got 2 people who are qualified, and one now we are acquiring as a student. So nuclear medicine technologist qualification currently going well. We are now producing our homegrown tech by doing what? If you have done your graduation in medical imaging, in either from 3 Polytech like ARA or UCall, Unitec, or University of Auckland. So that means University of Auckland produce every 4 year 40 students, approximately. I don't know how many seats they have currently.
Yeah.
We produce 50, same ARA and UCall. So we produce in 3 years, like in Unitec. I'm saying we, so currently. So that means around you have 150 medical imaging graduate students every year who are qualified for the X-ray and CT. So they are ready to be available to be accepted as a student if they want to continue, if they have energy and money left to go for the masters in nuclear medicine.
Yeah.
And if you really want to do like sponsored one, because you need practical practice. So Mercy, even in the public hospital, they have a student option available. So you need to put your expression of interest, and then you will be registering with the university. And it's in 3.5 year to 4 year, we produce our workforce for the nuke med tech. Now, radiochemistry, that's something which is actually a bit of a different world. So if you are a nuclear medicine technologist and you you worked in your hot lab with a technetium, and you definitely learn those radiopharmaceuticals. So you have the basic understanding. Now, radiochemists in Europe and America, what they do, they have a chemistry graduate or postgraduate, and they put them into the nuclear medicine hot labs or laboratory where they work in the different levels, and they call us radiochemist. And even some of the university like King's College London, they have a master's in radiochemistry. And ET at Zurich, where I was 2 weeks ago, they run very beautiful program. Somebody want to go and join there. In New Zealand, we don't have any. But I'm a dreamer. So when I was doing my master's, started my master, which is completing next year in radiopharmacy, I just thought that why not we start using our cyclotron site or other cyclotron sites, whether in Australia or New Zealand, create our own program, and we can go to the University of Auckland and think, can NZQ accept some sort of chemistry postgraduate or graduate, and they can do practical training. We develop some sort of on-site training program and can create our own radiochemist. It's a long road to go, but this is something I thought, and I shared with some of them who are dreamer or like me, and they say, yeah, this is a cool idea. So we are working on it, but radiochemists not, but nuclear medicine technologists, yes, we have enough people around.
Yeah, well, that's fantastic. It's very exciting stuff. Again, we need to have that expertise being built here, because you can't rely on a constant stream of people coming from overseas if we want to make the most of the promise of these technologies. And you're also almost finished a PhD, and amongst all of this stuff that you're doing, you're also doing your own
nearly
research
there.
as well. Yeah. So you've somehow managed to find a few extra hours in the day that the rest of us don't have access to.
Yeah. So
Clearly.
I just actually I don't know what I'm doing, but I'm doing that from last 4.5 years, and I'm really and the thing you can keep doing if you are attached to that, if your passion allows you. So if you're passionate, then you can do 1,000 things. Exactly. And if you don't find any interest, then you can't do a single thing. That's what.
Yeah. Are you able to share a little bit about your
Yeah, absolutely.
research?
Yeah. Why not? It's like it's a study related to lutetium
Okay.
177 PSMA INT is the name of the radiopharmaceutical
Yeah.
that you use for the treatment of the prostate cancer patient who are in their advanced stage. So we call it clinically MCRPC, metastatic castration resistant prostate cancer. So my participants were already exhausted, and we give them this lutetium treatment, and we wanted to check the one aspect which WHO even defined, the quality of life, because everyone say your blood tests say yes, your PSA is going down, your CBC says everything going down, HP is improving, but what patient is feeling?
Yeah. Objectively, you're improving, but subjectively, how are you doing?
Absolutely, that's the right term. So you need to go more into the some of the questions. So what I use for my research, I surveyed them with some quantitative like approved survey from which, so I haven't created anything. I just borrowed that survey, and 3 survey I use to detect their different well-being: physical well-being, social, emotional, and overall functional well-being. And also I check their family relations, because cancer patient doesn't do their journey their own. There are people around them. It depends. A whole whānau, do that journey. So we actually invited in the second part of that, knowing the quality of life, that I wanted to say, if your partner, family members, or friend who knows your journey from the beginning, can they come and talk about how you feeling now with this treatment? And there was no bias attached in that. Like, we were not saying that lutetium is the only thing can solve all the problems. Sure. We just wanted to know their journey, what they feel, because there's a few months left when you detect from that disease, like a clinically or research say 16 months to 22 months, and they mostly go on placebos. So there you are giving some treatment which is like a life prolonging drugs, which I say for the lutetium, PSMA, and then how it is working, how they felt before, how they feeling now, what the overall journey make them feel, financially how they have challenged, and outcomes are really emotional. Like my approach of concurrent triangulation, that's a methodology of a mixed method where I bring all the findings and then do the crystallization, and results make me emotional. Is ask me to ask question to our government and policies, because people who were capable enough to pay that much of money, because it's a private, so they were paying, how they arranged the money, they told their story. Like somebody sold their house, somebody is emotional that one word I would never forget, that I will be avoiding the grave by paying this much of money because this is saving my life. Somebody said my wife will be definitely widow, but I just want to leave some money for her. Wife actually changed her habit of around how husband is actually feeling and going through that journey, why the cancer. And she said, I just like to go out and go for the movie, but because he doesn't like, so I'm just spending time with him. So those emotional journey came across in my finding. I found it's improving the quality of life, but it's important part that which I've said in my presentation of the research, that I want to add some life into the remaining life of that, and how we can actually detect that, are we really doing that or not. It was reflecting in that research.
Jeez, I imagine you conducted countless interviews, and there were multitudes of questionnaires filled out by the participants, and then you've been poring over that to
it was like a pretty much like a quant part is pretty easy. The questions is coming, probability tree or the t-test and all that apply, but then you need to interpret that. And the most tough part for me, because I come from the pure science part, and when you put me in a psychology part where I use thematic analysis, where you see the theme, so generating code and all that, but that was very good. That's the point where I felt more connected with my participant, because I was reading their interviews, then I was highlighting the points, and same time sometimes I've cried even when I was reading. And some of the participants is no more, but they said some really good thing about me as well. And one participant, I know he was about to give his interview, but he died, and then his son actually said, I want to give my interview behalf of my father. And then he brought some really interesting story. So that's a beautiful, I would say this is not like a thesis I'm writing. It's like people's experience.
Yeah.
There are many gap in it. I know every research is not complete, but we identified that as a group of my supervisor and everyone. But it will highlight some of many things, but and also human part of the cancer patient.
Yeah. I mean, obviously I'm active in this field from a clinical research side and a project management side. So I'm somewhat removed from the day-to-day experience of the patients that join my trials. And it's very easy to kind of look at patients in terms of how far through the trial they've completed or how accurate their data is or how many protocol deviations.
Yeah.
And it's easy to forget that that's an individual human life with a rich observation of their own life, as rich as mine, going through life and going through these experiences. And sadly, if they're in a cancer trial, have cancer and going through that. So it's easy to forget, but vitally important.
It is.
Because why else would we bother researching these new potential interventions if it wasn't to give, yes, an objective response, or also B, a subjective improvement in the day-to-day life, and by extension, the families. I mean, that's an interesting aspect that...
Yeah, absolutely. And I found in the space of the especially theranostic side, in my literature review, I found no one actually used this approach to going for the interviews of the families. There were... You can find like in a various stage of the prostate cancer, many research available where they just did interviews, some just did survey.
Yep.
But still, I would say this research is not only complete. Some of the things which I found that patient need a counseling at every stage.
Yeah.
They need to be reassured, I would say, and counseling is costly, like for them. But reassurance, the word I actually just left, the reassurance that they can still fight, they can still do it. And family members played an important role, but sometimes you feel more comfortable when you go out and talk to someone else whom you don't know, and where you can drain more out of you, or you can say, yes, this is what I'm feeling. So it's a lot. And I'm pretty critique in some time about when people's published papers and all that, this new isotope is coming, this radiopharmaceutical is coming, and okay.
Yeah.
It takes 5 to 10 years to come to my lab,
Yeah.
right? So what are you trying to say? And how many people will we get benefited? Like, for example, if I would say 500 plus patient every year in New Zealand converted into the advanced stage of the prostate cancer, are all those patients eligible to get this, in the situation to get this treatment of like lutetium, I'm saying, or any costlier treatment that you are offering? Only few who has money. So government need to think about it. It's need an approach. It's not like a one treatment I'm talking about. It needs something that health we say is your right, but is this really we are saying it's a basic right? We like for the Wi-Fi, but are we really looking for the health? Like you have to go, this is approved, but this is not approved.
Yeah.
And this is like bizarre.
Because I've had a guest on to talk about the Pharmac piece, which is quite interesting. Pharmac was really great in the 90s. It was cutting edge, cost minimization analysis, make sure that we get the best bang for our dollar. But now the world's moved on, and now it's cost utility analysis, cost benefit analysis, if you really want to get aggressive with it. And those are the important things, because you do have to put somewhat of a dollar on human life, because you do want to advocate for a well-lived life, right? What you're doing is kind of adding to that. I mean, these patients are really having a hard time with their cancer, so they've exhausted all of the avenues. They are getting additional treatment. It's very costly, but what is the health outcome from a subjective standpoint?
Yeah, absolutely.
Yeah, it's really, really interesting stuff. Well, Madhu, this has been really awesome to talk with you. Really appreciate your time. We could spend hours talking about all the different facets of it, I'm sure, and we'd definitely love to have you on maybe in another year or so, because we can pick up. But where can people go if they want to find out more about nuclear medicine, molecular imaging, yourself, Mercy, if they want to find out more?
So if they want to contact me, then obviously I will not give my phone number, but they can definitely contact me on my email address, which I can give it to you for the comment.
Sure.
Yeah.
Yep.
So you can put that in. And if more information required, then our sites of Mercy are two currently, which is equipped with the PET-CT. One is the 100 Mountain Road, Epsom. So you can find me there on Wednesday and Thursday. And sometime on Tuesday, you can find me in Milford, 129 Shakespeare Road. So we are providing quite high-tech PET-CT services. And new things which is actually good for the New Zealand point of view, because as we just discussed about the frustration of equity and, approach and how the health system can improve. So Mercy taken an initiative, as we do always. We are bringing the first mobile PET-CT, and what we will be offering on that, not only the FDG, but also gallium PSMA scans.
Wow.
So that can be produced by some really remarkable kit, and I can take the name on the air, Telex, which is obviously, so they're a kit, Illucix, that's really game changer. Then you can just use with that GMP generators. It can be fit very well on the truck, and we can make like at least 3 patient dose, 3 in the minimum, and even go over 4, but depends how much radiation you have.
Yeah.
And we can give that service near to your home if you're in the Northland somewhere, wherever you like. So there are more details coming on it, but we will be on the
Very
road
exciting. Yeah.
taking that advanced modality next to your house.
Yeah.
So
Well, that's awesome, right? I mean, we can't keep these new technologies to the metropolitan elite in Auckland and Wellington, for example. It needs to be more widely available. That's really awesome.
yeah, but I will not be on the truck, but definitely you can find someone who is really good.
There you go. Good stuff. Well, thanks so much, Madhu.
Thank you so much.
Yeah, cheers.